Audiology evening, and I'd like to welcome our online viewers from the HSC and our students, including online our students that have attended here today. I'd like to introduce our speaker tonight, Professor Mark Lutman. Mark Lutman joined the Institute of Sound and Vibration Research at the University of Southampton in 1995 as Professor of Audiology from the Medical Research Council Institute of Hearing Research in Nottingham. He was headed by SVR Hearing and Balance Centre, which includes the South of England Cochlear Implant Programme, and Deputy Head of ISVR with responsibility for education. He is an audiologist with main interests in research and teaching. He was President of the British Audiology Academy of Audiology from 2007 to 2008. He has a BSc in Engineering Science, an MSc in Sound and Vibration, and a PhD in Audiology, all from the University of Southampton. In 1989, he jointly established the first paediatric cochlear implant program in the UK. His research interests include developing and evaluating processing algorithms for hearing aids and cochlear implants, measurement of cochlear function from otoacoustic emissions, neonatal hearing screening, cochlear implantation, psychoacoustics, epidemiology of hearing impairment, and noise-induced hearing loss. So I'd like to welcome Mark.
Thank you very much for that kind introduction, and thank you all for coming along to listen. The issue that I'm going to be talking about is a very common problem. That's one of hearing loss. And I've tried to estimate some numbers for the Irish population. And I understand the Irish population is something like 4.7 million. And amongst that population, the number over 50 years of age is 1.36 million. Thank you very much for that kind introduction, and thank you all for coming along to listen with hearing loss. So it is a substantial issue that I'm going to be talking about that we're talking about. Common problem. That's one of hearing loss. What is the problem or the burden of numbers hearing loss? Irish population. And a very interesting analysis was done recently by Kieran O'Neill, who's Professor of Economics at Galway, 50 years of age. He did this analysis actually in the UK context. Thank you very much for that kind introduction. What he calculated was that the total burden of hearing loss in the UK amounted to a value of £30 billion. So very, very substantial. The largest amount of that hearing loss was the sort of personal cost to people was a reduction in their quality of life. But the remaining 4 billion, which is still a substantial amount of money, was a financial cost. This cost arises from various things, like reduced productivity, and that people retire earlier than they would otherwise because they're struggling with their hearing, maybe at managed meetings or whatever. So or working in a lower grade of job than they would otherwise, so they're paying less attention to people in their tax revenue altogether. But there may be other costs as well, which is still a substantial amount of money, with a financial cost. This cost arises from various things, like reduced productivity, people retire earlier than they would otherwise because they're struggling with their hearing, maybe at managed meetings or whatever. So or working in a lower grade of job than they would otherwise, so they're paying less attention to people.
So, £4 million there. So if we translate that
to the population of Ireland, we have a financial cost. That's just the financial part, not the personal part, of about €400 million per year. So that's a substantial amount of money. And surely, if we can make a dent in that cost by better treatment of people with hearing loss, this would be a substantial and important saving for society. So my talk is based on that sort of idea that by making sensible financial cost, that's just the financial of how we deploy healthcare, we can make genuine savings to the society, which is basically the money that we pay in our taxes and so forth. So first of all, before I get into the details of the sort of health and the health economics, I want to give just a little bit of background about hearing loss, recognising that we have a public audience here. The most common causes of hearing loss I've divided here into preventable and unpreventable types of hearing loss. The most common preventable cause is noise exposure, for example at work, or people shooting, or perhaps leisure pursuits, going to nightclubs without hearing protection and so forth. And clearly all of those things can be prevented by wearing suitable hearing protection. Another common cause, or potentially common cause, is the use of ototoxic antibiotics, for example intravenous gentamicin. These should be properly controlled by good healthcare, and in developed countries they generally are. If we look at a wider worldwide context, they're less well controlled, and there are, in some countries like China for example, very substantial numbers of people who go deaf through health treatments, through antibiotics. Also, common chemotherapy compounds, particularly platinum-based ones, have a very substantial risk of hearing impairment, and it may be unavoidable to use those treatments. Of the unpreventable sorts of hearing loss, increasing age, which of course affects all of us, is the most common. I say it affects everybody. It affects everybody even from quite a young age. People's hearing starts to deteriorate from the age of probably 25 or 30 years in a gradual way, but the worsening becomes greater and more rapid in later years of life. Maybe say after the age of 55 or 60, the deterioration becomes much more noticeable. There are also some genetic syndromes which are associated with hearing loss, and also infectious causes such as ear disease can cause hearing loss. As they're classified by measurement, there are two main sorts of hearing loss. There is conductive hearing loss, which is basically a hearing loss which prevents sound getting to the inner ear. So the inner ear is the part of the ear which picks up sound and conveys that as messages in the nerves to the brain and gives us the perception of hearing. So there are different ways in which sound transmission may be affected. A very trivial one, I suppose, is ear wax. If it completely blocks up the ear canal, will give a feeling of deafness. Or also middle ear disease. Most people will have experienced at some time they've had a cold, and this has caused an infection of their middle ear and caused some deafness, which fortunately is temporary in most cases. All of those forms of hearing loss, in most cases, can be treated fairly readily, and many are therefore reversible. The other main sort of hearing loss is what's referred to as sensory neural, and this, in most cases, affects the inner ear, or the cochlea as it's called, which is the sensory part of the ear, which I mentioned earlier, converts sound which reaches the cochlea into nerve impulses travelling towards the brain. Examples of sensory neural hearing loss are the hearing loss that we get through increasing age and also noise-induced hearing loss. These sorts of hearing loss involve the death of cells within the inner ear, and they are irreversible. We generally classify the magnitude of hearing loss with simple adjectives: mild hearing loss, and in technical terms this will be a hearing loss of between 20 and 40 decibels, moderate hearing loss 40 to 70 decibels, severe hearing loss 70 to 95 decibels, and profound hearing loss would be over 95 decibels. So amongst that range, people with moderate or severe hearing loss can normally be helped with acoustic hearing aids, which amplify sound and overcome to an extent the deficit that's happening in the area. Once we get to profound hearing loss, hearing aids don't really work well enough, and then we're getting into the territory where people may well be helped by a cochlear implant, which is a device which is inserted surgically into the ear and bypasses the inner ear and will generate electrical impulses which go directly into the nerve and then travel up to the brain. These are a relatively new innovation. They've been around for about 30 years now, but they have been a massive help to people who otherwise really had no useful hearing. So what does the ear look like? You can see some examples on the front bench there of models, and we have a picture here which is an artist's drawing of the ear. I should point out that the models in the front are larger than normal size. What we can see here on the picture is obviously the outer ear, the pinna as it's called, which is the flap that everybody can see. There's the ear canal here and the eardrum. So sound travels along the ear canal and makes the eardrum vibrate. The vibrations are transmitted by these little bones, which you may remember at school have got Latin names for the, what are they? Hammer, anvil and stirrup, which are the English words. I find it easier to use Latin words because that's what we teach. Anyway, they act as a little chain transmitting vibrations to this spiral-shaped part, which is the inner ear or the cochlea. It's called cochlear because cochlear, I believe, is the Latin name for a snail, and because of its coiled shape, it looks a little bit like a snail, at least in this drawing. So the really important bits are in the cochlea, which I'll describe in a bit more detail as we go along. And then from the cochlea, there's the auditory nerve here, which has many, many nerve fibres. And these nerve fibres transmit through nerve impulses the sound through the brainstem and to the brain and give us the perception of sound. Here we have another drawing which is really just a magnified version of the cochlea, and the arrows show how vibrations which are transmitted into the fluids within this spiral shape are transmitted along a partition within the cochlea here. Now, all these, I should say, are artists' drawings, and they're a bit misleading, really. They look as though this is actually a physical structure in its own right, but really all this encasement is solid bone of the skull, and there are really just canals in solid bone. If we go to another level of magnification here, you can see on the outside here, this is where the bone starts, but inside there are membranous structures, and particularly there are structures in the middle which are sort of pink and red in the slide here, which is where the business really occurs. So sound travelling through the fluids here, either side of this partition, make this partition vibrate up and down. And if we go to another stage of magnification here, we again have the vibrations up and down caused by sound. Well, as the membrane here vibrates up and down, because it has this structure on top called the tectorial membrane, it behaves a little bit like a hinge, and so as this part here vibrates up and down, the tectorial membrane moves sideways, and so there are shear forces which act on the little hairs which are sticking out of the top of these cells that you can see in the inner ear. The cells that you can see here in the dark brown colour are connected to the auditory nerve, and those are the ones which transmit the vibrations from the cochlea here up to the brain. So you may wonder, why do we have these other hair cells, which are called the outer hair cells? Well, they are the really clever bit. They don't work really to generate nerve impulses. They mainly generate an amplification within the inner ear. So as they're stimulated by this shear force across the hairs on the top, they are stimulated to contract or expand their length. And their contraction and expansion of length actually amplifies the vibration of the basilar membrane. And it may amplify this vibration by a factor of up to 1,000 times. So it's like you have these rows of little soldiers that are jumping up and down to make the basilar membrane, as this membrane is called, vibrate even more. So this amplification of up to 1,000 times translates to 60 decibels of hearing. So if we didn't have this wonderful sensitive amplification mechanism in our inner ears, we would all have a hearing loss of 60 decibels, which is quite a substantial hearing loss. It would be towards the upper end of the moderate hearing loss range. The reason I'm focusing particularly on these outer hair cells is they are the ones which are particularly vulnerable to damage. They're the ones that are mainly damaged by noise exposure. They're mainly the ones that are damaged as we get older. The damage occurs because there are basically toxic byproducts caused by their normal operation, like in all cells of the body. If they're functioning well and normally, those byproducts will be taken away and everything is fine. But if there is some failure or some reduction in the ability to deal with these toxic waste products from the cells, they accumulate in cells and they start to damage the cells themselves. They may either cause direct damage to the cells, or alternatively they may damage the DNA within the cells. If the DNA is damaged, the cell starts off a process which is sometimes termed programmed cell death, which is a protective mechanism in the body where the body is saying something's going wrong here, we had better shut down this cell. And either way, whether it's structural damage or programmed cell death, the cell dies and is replaced by scar tissue. So this is the main mechanism of hearing loss in most people for most causes. Here we have a picture of the tops of some of those cells. These are healthy hair cells, and you can see this sort of W-shaped formation of hair cells sticking out from one outer hair cells. They're really very pretty here. These are actually taken from a laboratory animal, because it's normally very difficult to get volunteers to offer to have their inner ears taken out for this purpose. I don't know why. In humans, the picture is not quite so tidy and neat. But if we look at this slide, this is a similar sort of orientation. But this is actually an optical microscope picture where there's been staining used for the cells. So healthy cells are stained black on these pictures. And there are two parts of the picture. If we look at the bottom part here, this is looking down on rows of outer hair cells and inner hair cells. And this is a healthy ear. We normally have 3 or 4 rows of outer hair cells, but you can see there's a certain amount of raggedness. But that's just normal. But in the top part of the picture, we have the corresponding situation where an animal has been deliberately exposed to noise. And what we can see here is the outer hair cells are virtually totally wiped out, and even some of the inner hair cells are being damaged here. So this is showing the sort of damage which occurs for noise exposure. And as I said, similar sort of damage occurs when we get older. So that's really just the first introductory part of my talk, where I was setting the scene about how the ear works and the common sorts of hearing loss. Are there any questions at that point before I go on to talk about the main issue? All good so far? Good. Right. What I'm going to put to you is a proposition for a thing that we as society ought to do, in my opinion. And this proposition is a screening test for adults around the age of 60 years for their hearing. So the idea is to add this hearing test, simple hearing test, to the list of tests that are normally done by general practitioners when we reach that sort of age. I'm 66, so I'm in that age group very much. I'm nearly 66, I'm actually 65, not quite. The idea really is to get people to do something about their hearing problems earlier than they might otherwise. This will obviously lead to a benefit that if people do something about their hearing earlier, they'll have more years left in their life of the benefit of having done that thing. But there are other important issues too, and benefits. It's well known that when people are provided with hearing aids, it takes some time to get used to the hearing aids. It needs some personal perseverance, but also the brain needs to make some adjustments to the different sort of sound that is delivered by the hearing aid. And the brain adjusts much more easily when we're younger rather than when we're older. So hearing aids actually work better when they're fitted earlier. That means that if we were to take, say, two identical twins, and one twin was fitted earlier on, and another one later on, when they get older, even though they might have identical hearing loss, the one who's fitted with hearing aids earlier is likely to be doing better with their hearing when we look at them later than the twin who delayed. Also, there are potential economic benefits, which I've already foreshadowed earlier on. They may be able to work longer, more productively. There may be some benefits to their health. I had a question.
Yeah, just a slight question there, because my understanding is that it's not just that we're a bit older and it's more difficult to adjust, but that if you've left it for a period of time, and there are certain elements of sound, elements of speech that you can't hear, that the brain may reorganize itself, cross-modal reorganization or something like that it's called, so that when you do get the hearing aids, let's say after this period of time, 5, 10, 15 years you've waited, it's not just that you're older, but it's actually that your brain has forgotten how to process those sounds.
The question was, are there problems because if we don't do something to help our hearing, our brain may reorganize itself to deal with the impaired situation and may then find it difficult to reorganize itself back for the amplified sound. That's an important issue, and what you said is exactly correct. The brain does tend to reorganize itself according to its sensory inputs, and so that is an issue there. There's another thing which has been shown very nicely by a very recent French paper, something which has been suspected for some time, is to do with the issue of dementia. And what they have shown in this study is that people with poorer hearing suffer worse with dementia, and helping people with hearing impairment by providing them with hearing aids tends to offset or delay the onset of dementia. So there may be benefits again there with less problems arising from developing dementia, which happens increasingly commonly as people get older. Again, people may live independently for longer, and this may benefit not only themselves but other members of their family incidentally. So there's lots of possible reasons for doing this. Generally speaking, in the public health domain, screening tests are evaluated according to a set of well-known and well-published criteria, which were originally published by Wilson and Younger. and these have been established by the World Health Organization. And screening for hearing satisfies those very well. So, for example, it's an important public health problem because lots of people are affected. We understand the natural history of hearing impairment, so we can know what to do about it. We know that earlier intervention leads to better outcomes, as I've said. There's an easily accessible treatment, which is relatively inexpensive. And we know that a lot of people don't actually take up the treatment unless they're pushed. We know that only about a third of people who would benefit from hearing aids actually have them. So it seems like a good candidate for screening, screening criteria. So what we really need to think about is it going to be effective or is it going to be cost effective? Now, asking the question whether something is cost effective leads into problems of deciding how you look at the value of money and the value of benefits and things like that. And it's actually probably not the most sensible question to ask. From health services research or health economics perspectives, it's probably better to ask the question, would this be a more sensible use of money than something we're already doing? Because if there is limited money, we ought to be spending the money on the most cost-effective things. So we ought to be comparing cost effectiveness against other alternatives. Another way that health economists look at things particularly is to compare them a new treatment or a new state of affairs with how things are at the present time. So, what is the effect of the change? And they look at the cost of the change, and the cost of the change is also compared to the benefit. Now, benefit is a funny thing, but health economists tend to evaluate benefit in a quantity which is referred to a quality adjusted life year. Often people call those QALYs. What we mean by a quality adjusted life year is it's the equivalent of having an extra year of life in perfect health. Now, developed economies such as Ireland, United Kingdom, United States, most European countries have thought about this, and they have more or less agreed amongst themselves that it's worth paying somewhere in the region of 30 to 45,000 euros to buy a QALY for members of their society. So that is roughly the state of play as it is at the moment. So what we need to think about in terms of health screening that I'm going to put as the proposition, how does it come in on that scale? Does it come in as being cost effective at better than, say, 30,000 euros? And if so, it's clearly a good candidate for the way we spend our health euros. So that's really the question I'm trying to answer. So a little bit more about quality adjusted life years. The first thing you can see on the slide here is the dictionary definition of quality adjusted life year. It's a measure of disease burden that relates to both quality and quantity of life. So basically, if you either gain or lose a QALY, it's like either gaining or losing a year of life in perfect health. I don't know how much you would pay for that. Think about that. If you were given the option, particularly it's best to think of the option if it's going to be taken away from you. Just imagine, towards the end of your life, you're still fit and healthy, you consider yourself to be in good health, and somebody says, we're going to chop a year off the end of your life. How much would you pay for that not to happen? As I said, the governments of countries like ours reckon it's about 30 to 45,000 euros. So, how I try to answer this question? The way I've done it is a standard health economics approach of modelling. So, what I've tried to do is model what would happen to a cohort of people under either the existing state of affairs or the new state of affairs where we have a hearing screening program. And there are a number of parameters that have to be assumed for that model. And what I'm going to do now is tell you what those assumptions are as the assumed parameters. I'm going to start off by talking about people aged 60 years of age. So we take a cohort of 60-year-olds. What we want to do is we want to identify people with a mild hearing loss of 35 decibels. Technically, this is measured over the frequencies of 0.51 and 2 and 4 kilohertz in their better ear averaged together. And we know that people with that amount of hearing loss are more than likely to benefit or say they benefit from hearing aids and will therefore continue to wear them. So the hassle of wearing a hearing aid is outweighed by the benefit that they feel. So that's the reason for that number. The screening test that's going to be done is a simple screening test, which is just to measure whether somebody can hear a tone at 3000 hertz or 3 kilohertz at a level of 35 decibels. So this is quite a quiet level. It's an easy test that can be done in a general practice. And the notion of the screening test is that it will be applied at the age of 60 and then repeated 5 years later at 65 and then a second time at 70 to hoover up people as their hearing deteriorates. So that's going to be compared with the current state of affairs where people just go along to visit their GP when they feel they would like something to be done. The modelling is done in 5-year cycles, and the analysis I've done, which has been published, was actually based on UK demographics and cost, because that's how it was. But Ireland is demographically fairly similar to the UK. It's slightly younger, but in most respects it's fairly similar. Costs are probably fairly similar too. So we've used the National Health Service perspective for costs rather than private sector treatment. The outcome that we measured is the QALY, as I've already described to you. And we've assumed that people live to the age of 85. So people will go on collecting benefits up until the age of 85 years, which is a reasonable life expectancy. Another technical point is that the value of money declines as time passes, so we've applied a Treasury discount rate of 3.5% to both costs and benefits in this study. And we've used something which is called a Markov state transition model with a cycle length of 5 years. Don't worry if you don't understand what that means, because I'm just about to explain in very simple terms. We're just imagining for this as well that we have a cohort of 100,000 people aged 60. Now, just to think in terms of the context of Ireland, Ireland has about half that many people who are aged 60 at the moment, okay, to give you an idea of scale. So this is our state change model. So people can be in any one of these boxes here. So they could be a person who is, at the moment, doesn't have a hearing aid, but they're eligible for a screening test. They're the right age. Okay. So they could change state by getting a hearing aid, and they would become a new hearing aid owner. Or alternatively, they could stay in that state of not having a hearing aid. Once they become a new hearing aid owner, in the next cycle they become an existing hearing aid owner, and they can recycle by staying in that state. And of course, everybody has the option to transition into the dead state at any time, and once you're in the dead state, you stay there. Okay. So this is basically the model we've used. The model accounts for the obvious characteristics of hearing loss. As people get older, they tend to have poorer hearing, so there's a higher probability of having hearing loss the older you get. We've assumed that the benefit that people get from a hearing aid is actually the same regardless of their age. That may be a little bit of an oversimplification, but that's how we've done it. And this particular analysis just looks at qualities. It doesn't look at those other sorts of benefits, like being able to earn more money and pay more taxes, or being able to help your family better, or things like that. So this is just focusing on the personal increase in the quality of life. The parameters that are used for the model are all based on a search of the literature to get data wherever we could, which was reasonable in most cases. We have very good data on the prevalence of hearing loss. We know how many people have hearing loss per age band, and that increases from just over 11% for people when they're age 60 up to over 60% aged 80. The screening test that we've envisaged here actually had 2 stages. The first stage is a questionnaire which would ask people whether they are willing to take part, and then they would get an appointment with their GP from that, and then the second stage will be actually going to their GP. That's not necessarily the best way to do it, but that's one way of doing things, and that's the way the model was set up. So we've assumed that 86% of people actually accept the first stage of screening, in other words, answer the invitation that they get one way or another, and 56% accept the visit to their GP. So we're not assuming a perfect world here at all. We have accepted that the screening tests that are used have sensitivities and specificities. That means they don't always get the right answer. So if we do, for example, the screening test in the GP practice just with a 3000 Hertz tone, this doesn't tell us necessarily the hearing at all the frequencies that are needed to tell whether somebody needs a hearing aid. So those lacks of perfection are also taken into account in the model, and there are well-known values for those. We've assumed that 2/3 of people will accept a hearing aid when it's offered, and crucially we've assumed, based on good research, that the benefit that's derived from having a hearing aid is about 7%. So if you have your health-related quality of life scale, which goes from 0 meaning dead to 1 meaning in perfect health, you get stepped up that scale by about 7% by being given a hearing aid. So it doesn't make an enormous difference to your quality of life, but it makes that much difference. That's what people tell us from research that's done. Okay, lots of more model assumptions here. We assume that people go on using their hearing aids over 5 years. 90% of people do that, and that 62% actually in the long term go on using their hearing aids. We've assumed that in the comparative situation for the people going on to their GP practice, things are a bit better. 81% go on using their hearing aids. Maybe that's because they decided to go along in the first place rather than being sort of pushed by the screen. Again, all these figures derive from literature evidence. The costs there in pounds, and the Irish costs of providing hearing aids, I think, are very slightly more than those costs, but not much. I looked up the Specsavers website, and they have a package of 2 hearing aids for €750, and other aftercare built into that. So it's really commensurate with these figures. A fairly basic hearing aid, I should say. Okay, so that was the main scenario we looked at, which was people aged 60. Just for fun, we thought, what would happen if we did it at 55 instead? So we looked at that too. And also we looked at targeting people with slightly less hearing aid and tried seeing if getting hearing aids at a lesser state of hearing impairment would be, how would that work out too. So a few different scenarios there. Okay, this is the only really technical bit here. If you don't like statistics, just shut your ears. But when you're doing these sorts of analyses, you start out with a load of assumptions. And of course your assumptions may be wrong. Things may actually turn out better than you assume, or maybe worse. But you have to take that into account, otherwise you're on shaky ground. So the way that health economists deal with that is they adjust all the assumptions up and down over a reasonable range, and they run lots and lots and lots of different models, changing one parameter or all of the parameters randomly in different ways to see what happens. So this gives you an opportunity of seeing, what's the robustness of your analysis, and also what's the absolute worst case scenario if the buttered toast always lands buttered side down and your assumptions are really not as good as you thought they were. So this is something you have to do, and the way we did that was by random drawing of parameter values across a 95% confidence interval in those parameters. We jiggled with the costs by plus minus 20% for the main cost, and then screening costs by plus minus 50%. And we ran 10,000 simulations with all those sorts of things, which gives you a good statistical base to see how robust things are. And we also did something which is called one-way sensitivity analysis, which is basically to identify what are the things that really matter. And it actually turns out that most of the assumptions you make don't matter a toss. You can put them anywhere. It doesn't really make a big difference to the overall conclusions. And there's actually one or two things that are the key parameters there. So what we found from doing all this is that most of the variations were eliminated by something that's called extended dominance. That means that there's just one or two things that are really important, as I said. But to cut to the chase, and this is really the result of all that analysis, when we take our main scenario of 100,000 people of 60 years of age, and we compare the two possible situations. On the top row here we have the existing state of play, which is GP referral, and on the second row here we have our new situation of a one-stage screen. How many QALYs do we get from those different situations? Well, with the GP situations, for this 100,000 people, we actually obtain about 10,000 QALYs for our money. And the money there, I'm afraid it's all in pounds because that's where the analysis was done, that cost us £13.2 million. With the new state of affairs, we have about an extra 5,000 QALYs purchased, and it costs us now nearly 22 million, so we've had to pay an extra £8.7 million to get that. And nearly all the cost of doing that is actually the provision of the hearing aids. The screening test itself, all that pales into insignificance really. It's cost virtually nothing. So when we divide the QALYs, extra QALYs we get by the extra cost, we get this number here, which is called the incremental cost effectiveness ratio, sometimes said just as ISA. So we have the cost of an ISA here, which is £1,787. Now it's the ISA, which is the thing which governments have tended to agree is worth having at a cost of, if I say it in pounds, compare with that number, £20,000 to £30,000. So if governments will pay £20,000 to £30,000 for a QALY, why on earth would they not pay £1,700? This is good value for money in anybody's terms of reference. We also looked, as I said, at different scenarios, and we looked at what was the most cost-effective scenario. And it turned out to be a one-stage screen at an age of 60 years, as we did for the main one, but actually targeting a lower level of hearing loss. So by doing that, it costs more because more people get hearing aids, but it also buys us a lot more QALYs. And when we do the calculation of the ISA for that, the cost reduces to £1,461, which is a very good value for buying extra healthcare. Looking at the sensitivity analysis, basically, if you take different variations on the assumptions, as long as we're prepared to pay at least £2,000 for a QALY, it's worth doing the screening using the normal method of looking at the robustness of these schemes. And even if we take the worst case scenario, where all our assumptions should be actually pushed to the worst end, it only comes out at £12,000. So even that is better than the £20,000 to £30,000 that's worth paying. So beyond all doubt, in health economics terms, this is good value for money. What I've described was how the analysis was done, but that doesn't mean things couldn't be improved. And I think things could actually be done a little bit better than that. I mentioned the sensitivity and specificity of the test that we used. And actually, we can avoid those things and actually get 100% sensitivity and specificity by the GP test actually being the actual test for what we really want to measure, which is the hearing thresholds at frequencies of 0.51, 2 and 4 kilohertz. So cut to the chase there. It would be quite easy for an audiologist to visit the GP's practice for an afternoon a month or something like that and do a proper test, and this would mean we had a sensitivity and specificity of 100% at that stage at rather little cost, and I think that would be a better option. It would slightly push up the cost of the screening test itself, but as I said, the cost of the screening tests pale into insignificance compared to the cost of treatment. Also, the types of hearing aids we have now are very small digital hearing aids. The research that was used to give us the estimates that went into the model was mainly done in the 1990s, when hearing aids were much larger and much poorer, so less acceptable to people and not performing so well. So the estimates we used for the take-up of the hearing aids and also the QALYs, or the increase in quality of life from a hearing aid, may be underestimates compared with current technologies. So that would also make things look better. And in particular, the form of hearing aid fitting that's become very common these days, particularly for people with milder hearing loss, is something which is referred to as an open fitting. This is where there isn't a complete ear mold put in the ear, but there is a very small, thin tube which carries the sound into the into the ear canal, sometimes referred to as a skinny tube, and it's just held in place by a soft silicone device called a dome. So this means that if you have one of these in your ear, you can hear by the natural route normally, but then you get the benefit of some added amplification, mainly at higher frequencies, through the hearing aid. So this has been found by people to be much more acceptable and much more beneficial than the more conventional sort of hearing aids. So for all these reasons, the estimates that I've put in the analysis may underrepresent the cost effectiveness of hearing screening. What I haven't looked at in the analysis at all is those potential ancillary benefits at all, like the increased employability or employment, increased earnings, tax receipts, the possible offsetting of long-term conditions like dementia from better communication ability, increased ability for people to live independently, remembering that the cost of looking after somebody in some residential care facility funded by the state is extremely expensive and would probably repay the cost of a hearing aid in a matter of days. And also ancillary benefits for other members of the family, either other members of the family having a better quality of life because their partner, for example, has better hearing, or better ability to care for one another. So, in conclusion, what I'm saying is that screening of hearing in adults around the age of 60 years would certainly be cost effective when gauged against the conventional willingness to pay threshold. We would gain approximately 8,500 QALYs for every 100,000 cohort based on the best option that I've showed on the slide, which is a screen for a 30 dB hearing loss at age 60. The cost of this, the ISA, is £1,461. And what I'm really recommending here, and I've recommended to sort of government in the United Kingdom, is that a trial should be established, a large-scale trial of hearing screening in this form, to make sure that the sorts of benefits that have been shown by this modelling analysis can be actually achieved in practice. Thank you.
So thank you to Professor Lutman for actually a fantastic talk. Has anybody got any questions at all? Colin?
Yeah, I'm Mark. The current model for getting a public hearing aid in Ireland sometimes necessitates referral to ENT beforehand. And I'm just thinking, given that lots of time that public witness can be 2 to 3 years, and onto adult audiology publicly can be another 2 to 3 years, that could amount to another 4 or 5 missed QALYs. Would that, I suppose, strengthen the argument in terms of the cost benefit and compared to places that wouldn't have it that way?
Yeah, the question to do with the need in some instances for people in Ireland to have to visit a GP before they get a hearing aid, and then also there being waiting times for that and audiology. Clearly, those situations are not optimal. From my way of looking at things, if somebody feels they need help with their hearing, I'm not sure that an ENT surgeon is going to be able to tell us whether that's true or not. Surely it's the person's own perception of their need, which is the important thing. The possibility that there may be some threatening condition causing hearing impairment is actually statistically quite remote. And in any case, why not get on with hearing aid now? Get on the waiting list to see the ENT surgeon, and that problem is no worse than it was in the first place. So I think those structural issues that may be occurring in Ireland are probably a little bit of a side issue that ought to be tackled on their own. And they don't really impact on the question that I'm asking now. Also, there is the route that people have to go to the private sector in any case. My understanding is that it's possible, at least for some people, to get some help towards buying a private hearing aid financially too.
Okay, is there any other questions? Don?
Has any other country adopted this approach to screening?
Okay, the question is whether anyone in any other country has adopted this screening approach. As far as I'm aware they haven't, although it's been discussed in many, many countries. I'm reminded actually of the situation of newborn hearing screening, which you have in Ireland, like most other countries now. And about 20 years ago, that was almost unheard of. But there were many, many countries getting together and talking about that. And it came a little bit like a tsunami that once one country had adopted that, everyone did really. And although I understand Ireland was a bit delayed compared to some other countries in that respect. But now, in most developed countries, all newborns have their hearing tested. And what I'm envisaging is we may have a similar situation here where it's recognised across the world that this is a sensible use of public money and that it will catch on really rather quickly.
Is there any other questions?
Yeah, Mark, following your model, obviously would have a dramatic effect on the demand for audiologists. Did you have a look at that?
And the question is, how would this impact the demand for audiologists? It would have some increase on the demand for audiologists, but actually the magnitude is not that great. You can see from the costs that were involved, that would actually encompass the salaries of the audiologists as well as the hearing aids themselves. And doing a mental back of the envelope calculation, probably a half to 2/3 of those costs will be staff costs. So you could work out, the number of audiologists that you could buy for that amount of money, and it's not actually a vast number of audiologists. So I think it's a tractable problem. Obviously it would be an increase, but not an enormous increase. I don't think that would be a substantial problem issue in a country where they have enough audiologists already. In a country where they don't have enough audiologists already, clearly that is more of a problem.
Thank you for that.
Just more comment than a question. I suppose, given the current flux and thinking in the UK and to some extent in Ireland and changes in pension ages and so on, I wonder is there a timely opportunity for to look at the economic contribution of older people in society and where the
Whole idea of screening for hearing aids fits into that, because if people are not going to be drawing down a state pension until 68 and possibly 70 by the time some of us get there, is it an opportunity to weigh up the economic benefits in terms of their contribution to society and being able to work for longer and push the agenda on that front?
Yeah, the comment is to do with changes in the pension age which are being implemented around the world really, and people working longer in order to be able to support the increasing number of even older people in society, and people's ability to hear and be helped in their hearing would interact with planning of people's longer working life. I think that's a very good point, and there's not too many young people here, but you can probably be thinking, I would guess, about working to 70, I should think, by the time you get there. So it will become an increasingly large problem. Well, I shouldn't call it a problem, an increasingly large feature.
Say that we go for eye tests at a certain age when we might think that it might be glasses. With the use of headphone sets, especially in the younger generation, should they not be contemplating getting a hearing test earlier than 50 age?
Okay, so the question is,
to manage maybe potential hearing loss.
The question is directed more at the issue of perhaps younger people who may abuse their hearing through listening to music too loud, whether it's at nightclubs or so, or it's listening through earphones or whatever. And has that caused an epidemic, you would say, of hearing loss amongst younger people, and should they get their hearing tested earlier? Well, in fact, the evidence that's available shows that hearing in younger people is no worse now than it was 50 years ago. It's probably a little bit better for general public health reasons. So the concerns about young people's hearing don't seem to have materialised in the way that's suggested. So there's a little bit of scaremongering, I think, in some of the popular press over these things. But that's perhaps also offset by the fact that nowadays it's relatively uncommon for young people to go and work in noisy industry without hearing protection.
I was just wondering about those the candle wax that's used, the candles that are used to move the earwax. Is that potentially damage your ear?
The question there is
Ear candles, which you should never let anywhere near your ears at all, and you should never use without a fire extinguisher. They're quack medicine.
Gentlemen, Gary, please sit back.
Really enjoyed the talk, thanks very much. I suppose just from maybe a slightly different perspective, I come from a pharmacy background, and I was just wondering if you had an opinion for the potential for hearing screening to be part of, I suppose, the increasing package of screening services that are becoming available there, and if that might be something that is done elsewhere, maybe successfully, I don't know.
So the question is, screening might reasonably be done in the high street, I guess, through pharmacies, for example, or perhaps other stores of that sort. The answer, I think, is yes. I think we're changing the way that we envisage healthcare much more to be a community-based healthcare and being more accessible. So shopping malls and high street outlets, I think, will become more and more important in the delivery of healthcare overall. Frankly, if you don't have to go there, you shouldn't go anywhere near a hospital, in my opinion.
And it would also potentially have, I suppose, the potential to benefit a cost-effectiveness analysis as well, if you can take it out of the GP surgery and maybe put it in the pharmacy, like you say.
Yeah, so the question there is about the cost effectiveness of high street delivery, and I think there are very many reasons why there are gains to be had by using premises for more than one thing, and the reduced costs associated with that.
And one more, if I could, would that be something that you would envisage would be possible for the pharmacist to be trained in and the equipment to be supplied to do initial screening? Or would it be, again, more of a collaborative model where you get the audiologist in to do the screening?
Whether the pharmacist could do the testing or whether an audiologist was needed. I'm sure a pharmacist could be trained to do the hearing screening. I doubt if it's actually the optimum solution, provided there are enough audiologists around. If an audiology department is serving a geographical area, their work would involve generally visiting a number of different places anyway, and they will get exposure to different sorts of patients, different sorts of situations as part of their work, and this also is part of their learning. And they can bring what they learn from all their different aspects of their work to each part of it. And I think what an audiologist would bring through their broader experience would actually probably outweigh the sort of benefit of not having to travel there. Testing hearing in itself can be done fairly easily, but when you speak to people with hearing impairment, they will very, very often come up with questions and issues which require more than just a screening test, but also some discussion and either advice or listening to. Often just listening actually is extremely important.
Is there any other questions or comments?
I'll just follow up on that. In the UK then, what percentage of audiologists will be working in the private or in the public sector?
It's the proportion of UK audiologists working in the private rather than the public sector. I would guesstimate about 20%, 25% perhaps.
Okay, gentlemen, back there.
My question is about the assumptions around the benefit, that figure of 0.068%. And if you could just say a little bit more about what the assumptions were, what's behind that figure?
The way that quality of life is measured is quite difficult, and very often it's done by not actually asking the people who have the problem itself, but by asking just ordinary people. And they will often be given us a vignette, as it's often called, which describes a particular situation and what people can do and what they can't do. and they will be asked to evaluate that situation. They give her a variety of different vignettes. And by asking a large number of people to evaluate these different vignettes, a sort of scale is devised. And that's been done with a very well-known measure around the world called the Health Utilities Index. It's originally developed in Canada, but it's used all around the world. And this has various scales in it, and it does actually, it's one of the few health quality scales which actually has hearing included within it. And that's rather crudely divided into, I think, 5 different levels. So the best level would be being able to hear somebody or to communicate with somebody by hearing, either in quiet or in background noise without a hearing aid. And then the more difficult situations are being able to communicate in quiet but not in noise without a hearing aid and so forth. So it's really a bit crude. But based on the percentages that are attached to those different levels, you can see how somebody would shift from one to the other by the provision of a hearing aid, and you can sort of work out the benefit in that way. And there have also been some sort of attendance studies, like people actually with hearing aids and using their Health Utilities Index with those people. So it's quite difficult, but it's actually nonetheless, I think, a fair estimate.
Okay, and would that be, in terms of other health conditions and possible benefits of various interventions, would that figure of 7% be on the higher or lower scale? You know what I mean, in terms of, let's say, if it was a cardio, a heart treatment or a...
Well, the hearing scale of the Health Utilities Index only accounts for so much. And there are things like there's a mobility scale, for example, which accounts for more. So if somebody's not able to get around at all, they would lose a lot of quality of life. Whereas if somebody's totally deaf, they don't actually lose such a large amount from their quality of life. And there's a way in which the interactions between these things can be combined. You sort of multiply together the factors.
I just wondered why you think what's there at the moment isn't working. Is there screening? I'm not an audiologist, so I'm curious as to why you thought there was a need for a new model and why this model, what's not working about what's there, or is there anything there?
Why isn't the current situation working okay? Well, we know that for various different reasons. It's well established that at the moment people will get a hearing aid about 10 years too late. So that at face value means it's not working. We also know from anecdotal but quite good indications that very often when people go and visit their GP and they say, I'm starting to get a bit of a problem with my hearing, they get told, well, what do you expect at your age? Because GPs have got a difficult job to do. They really have a whole load of different conditions they're trying to identify, and if there's no particular form of treatment that's in their hands that comes to mind, reassurance is their treatment, really. The same, incidentally, applies to tinnitus or ringing noises in the ear too, and very often people who have quite a lot of trouble with ringing noises in their ears are told by their GP there's nothing you can do about it, you'll just have to get used to it, which frankly is not terribly helpful.
No, but so basically what's there now, what you're saying is that people really turn up with symptoms.
People turn up with symptoms, and they turn up with symptoms which have been present for a long time.
Yes.
And the supposition really is that if they had been asked at an earlier time, or chivied along a little bit at an earlier time, they would have accepted they had a problem, and they would have accepted doing something about it.
So do you have any idea in your own head why hearing isn't given any, you know, I suppose, emphasis? Why do they emphasise, would say, other senses to be looked after and not hearing?
I'm not sure. Yeah, I'm not sure.
You gave the statistic of 500,000, I think, 0.5 there, which to me was shocking to read, you know, to read that even. I wouldn't even have any idea that that was going on. So I'm just curious as to why that wouldn't, you know, maybe stimulate people to do more about hearing.
Yeah, it's very difficult to get inside people's heads to know why they do things. But factors may be that hearing loss tends to come on insidiously and slowly, and people just make adjustments in their life. Also, older people tend to be stoical, and they put up with things, and their automatic response may be to just put up with it. Another thing is people often don't like to accept that something is deteriorating in them, and there may be a certain amount of denial involved there. And certainly we see lots and lots of denial. Very, very often you will hear stories such as, there's nothing wrong with my hearing, it's just young people these days, they don't talk clearly anymore. And things of that sort. So the psychology of it, I must admit I don't fully understand, and it's difficult to understand.
Thank you. Gentleman back.
At the back.
And just to add to the adjustments that people make, they avoid the situations, as you say, that they find troublesome, such as going down to the pub or going to their community group, going to family weddings, this kind of thing.
That's a good point. So, coping, I guess, is what you're saying is people may cope with their lack of hearing ability by living their lives differently.
Yeah, but that often contributes to the social isolation associated with hearing loss and the other related conditions like depression or whatever, the more prevalent. My last question, I promise, is my last one, and it's just in relation to the ISR figures that you are quoting and the general threshold that's there. Isn't it the case if you're trying to engage stakeholders like departments of health and government and so on, that the ISR for something like hearing loss, and it's related to this lady's last point, it doesn't grab people's attention the same way as, let's say, cancer screening or screening for heart disease, because that could be life or death, whereas hearing loss isn't necessarily life or death, but it is quality of life.
The question is really to do with the sexiness, I guess, of hearing loss, and when trying to persuade government departments about its importance. In a way, that's the reason why there are more formal ways of evaluating healthcare treatments. In the UK, NICE is the organisation that does that, and they try to look at things objectively in terms of published research and measures such as ISAs, rather than just thinking of it subjectively as to whether it's important. It's always difficult for any purchaser of healthcare to choose between one form of treatment and another, and I would hate to have that job myself. But there were just on the radio this morning, there was a piece about NICE having refused to accept that a drug which I think was for treating women in the late stages of breast cancer, which gives better outcomes than the currently accepted treatments, but is very expensive. And they refused to accept that as a fundable health treatment because it was just too expensive to gain the additional quality of life. But it's extremely difficult if you were faced with somebody who was going to die and to talk about the length of time they were going to live in the same breath as talking about helping somebody with a hearing aid. It's very, very difficult.
Any more comments or questions? Just one more comment, sorry. Just the link between the having a hearing aid and dementia. Is there a lot of research around that?
No, there's a very recent paper published. It only came across my in-tray last week, so I don't have it at my fingertips, but it was French. It was a large, I read the abstract, and it had large scale, and it was a very good study because it was a longitudinal study over a long period of time. I think the cohort was recruited in between 1990 and 1995, so fairly long-term longitudinal study of people, amongst whom there were some who developed dementia. So it's quite a difficult study to do, so it's not surprising there aren't many of those studies, but it would seem to be a well-constructed study.
Any final questions or comments? Okay. Mark will be around for a short while after the seminar if anybody's got any questions or anything they'd like to ask in private. But on behalf of President Kieran O'Carthy, President of the Institute, we thank you all for attending today, especially in such dreary weather, and we especially thank Professor Lutman for travelling from the UK.
Well done, Mark. Excellent.